Welcome to this presentation on emergency oxygen use in pre-hospital care. My name is Jon Hochstetler. I'm the supervisor of outreach athletic training services at Greater Regional Health in Creston, Iowa. First, I want to thank those at the Southwestern Conference that asked me to present on this unique topic, and I hope I do a sufficient job and can help some of you guys, in your decisions, using oxygen going forward. So conflict of interest, I do not have any. The views expressed in this presentation are solely mine. My views may not be the same as the views of Greater Regional Health, our clients, or my colleagues. Participants must use discretion when using this information contained in this presentation. The learning objectives for this presentation: identify the clinical indications and contraindications for the use of oxygen in the pre-hospital setting, understand how oxygen can be beneficial for the treatment of certain injuries and pathologies, know the regulations for proper storage, use, and maintenance of oxygen. So background on oxygen, as most of you know, oxygen is a colorless, odorless, and tasteless gas that is essential for the body to function and survive, and generally, as we think of it in sports, to thrive. We're constantly breathing in oxygen and releasing carbon dioxide. This was first recognized respiratory physiology in the 18th century by a physician. And disruptions in this process can be detrimental, as hypoxemia or SpO2 oxygen saturation, if it's less than 92%, can lead to deoxygenated blood circulating to the tissues. And this can lead to severe injuries and/or death. Oxygen therapy is generally considered when there's administration of oxygen at greater concentrations than that of ambient air, which is generally about 21%. As it pertains to medical care, oxygen is one of the most commonly used drugs in the care of patients with medical emergencies. About a third of patients are administered oxygen in an ambulance ride, and about 20% of hospital inpatients are treated with oxygen at any given time. So it's a very common treatment, in those settings. So as we kind of think of it in the athletic setting, it's trying to, decipher and decide when, it is applicable, if it is. So in 1940s, Dr. Edward Boland was the first kind of report positive outcomes with oxygen administration in patients with myocardial occlusion. From 1940 to the 1990s, oxygen was routinely used for the treatment of myocardial infarction. Kind of since then, with the lack of high quality of research, it has led to some professional conundrums, for medical professionals dealing with life-threatening conditions and little time for decision making. So it's really up to each kind of medical provider and your employer to really look at, what conditions, oxygen is recommended, and the quality of research, as far as the outcomes that has. And if there isn't a whole lot of that, then that's between the experts to really try to figure that out and set those guidelines. The current guidelines suggest the primary goal for utilizing oxygen in a pre-hospital care is to reverse hypoxemia, that oxygen saturation that I discussed earlier. As far as the athletic trainers' utilization of oxygen therapy, KD accreditation educational competencies include the administration of supplemental oxygen in patients with cardiac and respiratory compromise. So the students that are coming out of these accredited programs are going to have the ability and the knowledge, to administer supplemental oxygen if that, is in compliance with the employment setting that they have. The NATA position statement for preventing sudden death in sports recommends the administration of supplemental oxygen in medical emergencies for asthma and exertional sick leave. And I'm going to go a little bit more in depth on those two a little bit later when I go over indications and contraindications for oxygen therapy. So the importance for a consistent review of knowledge and skills. There's a recent study that showed that there was skill decay after about 6 months in athletic training students. So that generally will probably translate over to professionals as well. Is it something that, we need to be, kind of annually or regularly educated on use of it. And a study said that only 13% of secondary schools have access to oxygen. So if that few of schools at the high school setting have access to it, then I think it's something we really need to discuss whether or not what are the barriers for high schools, achieving that, or whether or not it's something, as we see here in that same study, the authors, suggest whether or not this is a luxury or a necessity. So the finding of that 13% in that study was not ideal, but it may indicate the lack of feasibility in providing athletic trainers with access to supplemental oxygen. Despite the inclusion of the application of supplemental oxygen in the education competencies, the high cost, inconvenient storage, and lack of practicality for sideline use makes access to oxygen a luxury only a few secondary schools can afford. For these reasons, the need for and feasibility of supplemental oxygen in secondary schools may warrant reevaluation as a recommendation. So that was kind of a statement in that previous study on the 13% of athletic trainers at the high school setting that have access to oxygen. I think it's something we all need to sit back and think about whether or not it is a luxury or necessity, especially in 2021, that we can or can't afford for our athletes. So as far as medical evaluation decision making is concerned, generally a general assessment, is going to be performed of vital signs, pulse rate, blood pressure, temperature, respiratory rate, and pulse oximetry. And this in the literature is called the fifth vital sign. And that's that SpO2 that I kind of discussed earlier, oxygen saturation. And generally this is going to be determined via pulse ox. The recommended diagnostic tool to assess hypoxemia and or the discontinuation of oxygen therapy, is this pulse ox. So it's generally pretty accurate within the 2 to 3% of arterial blood gas values. And generally the accuracy is going to decrease. It's pretty accurate in the 90 to 100% range. But as it gets a lot lower, like 80 or below 70%, it isn't as accurate. But again, when we're trying to determine when to start and discontinue oxygen, it's kind of the recommended standard for us to use. And they generally, the literature and the experts recommend below 94% of oxygen saturation warrants supplemental oxygen use. And you're going to administer that oxygen until you get that saturation in the target range of 94 to 98%. So general contraindications for the use of oxygen therapy. Against a lot of this, we probably won't see in our setting, but go over them just to go over them so you're aware there are some contraindications. Congenital heart disease patients with ductal dependent lesions, carbon dioxide narcosis in patients with obstructive pulmonary disorders or chronic respiratory insufficiency, flames and smoking. Unfortunately, it seems like it's common sense, but there are a lot of people that are on oxygen tanks that do, choose to either be around flames or smoking. And, there are, some issues with that, explosions and very unfortunate circumstances that happen. So indications for oxygen therapy. The first area I'm going to go over is cardiovascular. If there's acute myocardial infarction, stroke, the routine use of oxygen for treatment for stroke is not recommended. But again, we're looking at the presence of hypoxemia. For most of the medical conditions that, we're dealing with or seeing, the hypoxemia is generally going to be our best guide for administering. Cardiac arrest, obviously, if you have the ability to administer oxygen in an emergency situation, you have access to that. It is indicated. From a respiratory standpoint, again, we'll probably not see a whole lot of this in our setting, but just to be aware. So with COPD, with oxygen therapy, they generally call it the Goldilocks and the three bears approach. The oxygen levels need to be just right. And the decision needs to be made by a medical provider with substantial education and training for what that needs to be. Acute respiratory distress could warrant oxygen therapy. Acute respiratory failure, pneumonia, the admission decision should be made by oxygen saturation. Low oxygen saturation below 90% correlated with greater mortality and morbidity in those with pneumonia. So they kind of put the safer threshold for admission with pneumonia was 92% or below. As far as asthma is concerned, and this is what we'll probably see more often in our setting, generally it's recommended be administered for moderate to severe asthma exacerbations, and you're trying to get that oxygen saturation level to 94% to 98%. So this is a picture here of a few people with COPD and whether or not they need oxygen therapy. And again, probably not as much for us to really be aware of, but I did think that the person in the middle there really lets us know that it is important to know the oxygen saturation levels for when administering oxygen and not just blindly administering. So the person in the middle, the COPD, means that they have to work harder to get oxygen in the lungs, and it makes them breathless, but the levels of oxygen in the blood are normal. So as that parallels with other medical conditions, you may have someone that could be breathless, but their oxygen levels could be normal again without checking. And you could be doing more harm than good by just blindly administering oxygen. So just something for us to be aware of. When we're kind of administering oxygen, if we are, what is the recommendations and guidelines that we're going to have. So indications, some other pathologies, pregnancy, carbon monoxide poisoning, breathlessness. Again, this should be kind of determined using that oxygen saturation, the pulse oximetry, hemorrhagic shock, traumatic brain injury. There's some good articles in the military where they kind of go over administering oxygen for those with traumatic brain injuries and trying to help keep oxygen flow to the brain to promote healing. Hypermetabolic state caused by trauma, burns, and sepsis, loss of consciousness, hypoxemia, again, a lot of medical conditions. Kind of a general rule of thumb would be, if they have hypoxemia, that's going to be the main indicator for administration of oxygen. And exertional sickling. So as I mentioned earlier, kind of the two main indications, that we have in our profession are going to be asthma and exertional sickling. So I'm going to go over two of those conditions a little bit more in depth right now. So asthma is defined as a chronic inflammatory disorder of the airways characterized by variable airway obstruction and bronchial hyperresponsiveness. There are many triggers that include allergens, pollutants, respiratory infections, aspirin, NSAIDs, inhaled irritants, particulate exposure to cold, and exercise. Exercise-induced asthma is one of the top 4 non-traumatic causes of death in athletes. Approximately 1 in 30 cases results in an athlete passing away from asthma. It's most frequently in elite young athletes in the 13 to 21-year-old age participating in high-intensity intermittent sports. 70% of the exertional-induced asthma deaths occurred during training and competition, and 60% of these deaths were in football athletes. So, oxygen use for the asthmatic patient. The British Thoracic Society advises oxygen as a first line of treatment for all patients in cases of acute severe asthma. Forced expiratory volume, and generally that's going to be over kind of forced exhale for about a 6-second period, and then you're going to get these numbers and compare them to kind of normal ranges for that individual. And mild to moderate obstruction would be in that 40 to 79% FEV, and the severe obstruction would be below 40%. So that could be kind of helpful, in determining how that asthmatic patient is doing. And then obviously we're going to want to check for oxygen saturation via pulse oximetry. So again, we're going for that 94 to 98% range, and below that 94% range, could be potentially, recommended to administer oxygen. Again, that's going to be, between you and your treating physician through your standing orders. Another kind of common treatment is a B2 agonist for asthma, and this relaxes bronchial smooth muscles through its action on B2 receptors. However, in the literature, In some severe asthma attacks, the B2 agonists have been found to worsen hypoxemia when administered without oxygen. So that's it's a tool we have in our toolbox. We probably would rarely use it, but you would want to have it on hand in case you're in a medical situation that does require that. And some of us may not have, very high response times for our emergency personnel. So again, all these things need to be discussed kind of in that preseason phase with, all parties involved. Emergency management for asthma. Again, you can administer a short-acting B2 agonist to relieve the symptoms. In a severe case, rapid administrations may be needed. Generally recommended if 3 doses don't relieve the distress, the athlete should be referred promptly to an appropriate healthcare facility. Inhaled corticosteroids or leukotriene inhibitors can be used for asthma prophylaxis and control. A long-acting B2 agonist can be combined with other medications to help control asthma as well. And again, supplemental oxygen should or could be offered to improve the athlete's available oxygenation during asthma attacks. And it should be measured via pulse ox and administered until 94 to 98% is achieved. Lung function should be monitored with the peak flow meter. Value should be compared with baseline lung volumes and should be at least 80% of predicted values before they can participate in activities. If feasible, the athlete should be removed from an environment with factors, smoke, allergens that may have caused the asthma attack. So just some general recommendations, for emergency management of an asthma attack, the last few slides. Again, ideally, this would all be kind of discussed pre-season between you, all parties involved, including your team physician, on how they would want you to have that treated. And as I'll discuss later, if oxygen is something that your team physician wants you to administer, they should have those specifics. I wanted to go over this clinical case. Some of you may or may not be aware of Rashidi Wheeler. He was a Northwestern defensive back in August 3rd, 2011. He had a history of asthma and died during a preseason conditioning test. So I want to take a closer look at that case and really try to emphasize and look at whether or not there are things that could have been done that could have helped him have a better outcome. So unfortunately, there was kind of a tragic storm of events. So literally there was a storm the night before that led to the conditioning test that they had scheduled being moved from the grass to the turf field. They had above average heat and dew point, and I kind of put the normal, heat highs, and generally with dew points, 70 or above, it's considered oppressive and dangerous. So that dew point was already on the oppressive and dangerous level, so pretty close. So again, you have, above average heat and dew points. And then we have this preseason conditioning test that consisted of 10 10-yard sprints, 8 80-yard sprints, 6 60-yard sprints, and 4 40-yard sprints. Tragically, Rashidi had multiple falls during the exercise and a post-test collapse, and the athletic training staff found him unresponsive with an inhaler in his hand. So it took several minutes after the collapse before athletic trainers realized he was having an asthma attack, which led to cardiac arrest. The athletic trainer started CPR. Unfortunately, there was no AED or supplemental oxygen on site. There was no working phone to activate EMS, so there was a delay in that process. And the cause of death was determined to be exercise-induced asthma. So the tragic aftermath, from this athletic tragedy is I think we need to evolve that next man up mentality where, someone goes down and we just continue with business as usual. So after Rashidi's death, the workout was recorded, and his mother watched that recording, and I think the visual imagery of it just hits harder and probably made it a little bit harder for her to kind of deal with the whole situation. So the video showed staff continued timing players while her son Rashidi Wheeler struggled to breathe. And this is the quote that his mother had said: "To them it was business as usual, and I'm enraged. I trusted them with my child." So I think we need to evolve that next man up or that business as usual. If we're having someone going through a medical emergency, it is okay to kind of be empathetic and, of that individual and not just treat it, as another, injury that comes with it. Some of these things, are preventable. And if there is an emergency that happens, kind of treating it, as it's your own child, giving them the care that, they really need. And in this situation, there was a civil lawsuit filed, and Rashidi's Wheeler family was awarded over $17 million. But it wasn't for financial reasons. She just wanted her son to be remembered. So there was an initiative after his death called the RAW Initiative, and this legislation was in regards to mandating AEDs at all sporting events and make sure staff are trained. And another thing that I want to kind of point out, obviously an AED would have been extremely helpful. Hopefully, in this situation, it might have had a different outcome. But for the asthma case to not get to that cardiac arrest, potentially having supplemental oxygen on site, would hopefully prevent it from even get to that stage where you needed the AED. But this was the legislation that was introduced after his death. And here's a quote from this legislation, or after this legislation was passed. Rashidi's smiling from heaven today. Will said in a statement after then Illinois Governor Rod Blagojevich signed the bill into law. Weaver's actions in the signing of House Bill 1279 ensured that his friend's tragic loss of life is not in vain and ensures that other students and their families will have the opportunity to pursue their dreams in a far safer environment. So if you're an athletic trainer in Illinois, I think anytime you kind of see an AED at your clinical site, try to think of Rashidi Wheeler and or all the other, athletic tragedies, that have led to us making sure that, we have AEDs on site. And another thing to think about is, this case really led to the AEDs, the AEDs being kind of mandated. But I also think another thing we need to consider, as I mentioned earlier, is, that access to supplemental oxygen that, again, in some of these, respiratory cases or other medical conditions, that can, help prevent them from going to the cardiac arrest stage. So we have access to that in the AED, again, trying to make sure we have as many check boxes as we can to ensure positive outcomes, regardless of the medical pathology. So clinical case reflections, one thing I want you guys to kind of think about, was the conditioning test a good sport-specific measurement for a defensive back? And again, the conditioning test was 1,000-yard sprints, 880s, 660s, and 440-yard sprints. Me personally, I do not think that was a very sport-specific or position-specific drill. And again, I think it's important that strength coaches and athletic trainers work in conjunction to ensure that we're having safe conditioning sessions. So again, did the conditioning test cross that line between safe and dangerous? Again, I think that's kind of a personal decision everyone can make. I think it did. There may be others that might argue that, it might have been, sport specific for football. Again, that regardless of my opinion on this, it's a conversation that strength coaches and athletic training staff should have before each conditioning season. What on-site emergency equipment could have been on site to help increase his chances of living? And I think AED and supplemental oxygen, and obviously, trying to get to him before it became a medical emergency, before he collapsed and was kind of, unresponsive for a few minutes. So how do you feel about a culture that continues a conditioning test while an athlete is experiencing a medical emergency? And again, this is bigger than Rashidi Wheeler in regards to this. It's kind of that next man up culture. And there's a lot of cases of severe injuries or deaths where kind of the football team for a period of time kind of continues as business as usual. And I hope at some point we can kind of get to the point where we get past that type of mentality and we're allowed to be kind of empathetic and, worried and still implement that high level of care on our athletes. Sickle cell trait. So exertional sickling is what I'm going to kind of go over here. So with sickle cell trait, it's the inheritance of one gene for sickle hemoglobin, which is abnormal, and one for normal hemoglobin. Generally about 40% is hemoglobin S and about 60% is hemoglobin A. This is different than sickle cell disease. With sickle cell disease, their hemoglobin S is going to be above 50%. Some clinical considerations, with your athlete with sickle cell trait includes exertional rhabdomyolysis, splenic infarction at altitude, venous thromboembolism, exercise collapse associated with sickle cell trait, and exercise-related sudden death. Sickle cell trait is one of the top 4 non-traumatic killers of collegiate athletes. And another aspect I'm going to touch on is going to be exercising at altitude with sickle cell trait and the potential impact on oxygen saturation. So pathophysiology, for someone with sickle cell trait, that can lead to the red blood cell sickling, getting kind of log jammed, which can lead to, all those medical conditions I kind of mentioned earlier. But it's muscle hyperthermia, lactic acidosis, red cell dehydration, and hypoxemia that I had kind of mentioned earlier. So this is a flow chart of how sustained exercise in an individual with sickle cell trait can lead to sudden death. So as you'll see at the top of the chart, you have that sustained exercise. You can have, again, those 4 factors that I talked about, the pathophysiology with hypoxemia, acidosis, hyperthermia, and the red blood cell dehydration. So if you kind of push past that point of no return, you'll see on one side the skeletal muscle metabolic failure, which is that rhabdomyolysis can occur, which leads to hyperkalemia, or the potassium leaking from skeletal and vascular smooth muscle cells that can lead to cardiac arrest or pulseless electrical activity, which can lead to that sudden death. Or on the other side, sometimes even before that rhabdomyolysis can occur, you can have that red cell sickling and occlusion that leads to that hyperkalemia that can affect, sudden death, as I mentioned earlier. And again, I want to say it's at least hypothesized, the potassium without rhabdomyolysis, it's almost 50-50, where you have the rhabdo and then the hyperkalemia. So again, it's something that we all need to be aware of how, you can get from that sustained exercise and how it can lead to really significant and life-threatening complications for the individual with sickle cell trait. So this table shows non-traumatic causes and features. And the big thing I just want everyone to see here is just kind of differential diagnosis between exertional sickling and some of the other common non-traumatic causes of death. So with sickling, you'll have someone that's going to have weakness that's more than pain. It's not that the individual is going to be completely painless. There's going to be significant pain, but they're going to explain severe muscle weakness. And that's kind of different. With cardiac, there's no cramping. And obviously when you have muscle cramps, there's kind of that, rock hard muscle. This is going to be kind of flaccid muscle tone, muscles that look normal. With sickling, they're going to slump to the ground, again, compared to kind of cardiac. The individual is going to fall suddenly and not be able to communicate. They're going to be unconscious. So again, that's going to be kind of a difference with sickle cell trait. With heat stroke, their cognitive abilities are going to be deteriorated or decreased significantly. With the temperature in the body, again, their core temp's going to generally be below 103, which is going to help, differentiate from heat stroke. And again, this is generally going to occur early in sessions. Compared to cardiac, there's no warning. Generally, heat strokes can be later in the training. And then with asthma, generally it's known asthma, prior episodes. Again, they're going to be breathless, gasping, panicking, and generally it's going to be kind of known. So these are just some non-traumatic causes and features now to kind of differentiate between those, but also, in regards to this specific slide, for us with exertional sickling, trying to understand and notice when someone is having complications. So understanding treatment for exertional sickling, hyperthermia, again, generally not going to be the case with the athlete with sickle cell trait and exertional sickling, but if it's needed, you can do the cold water immersion. For lactic acidosis, oxygen and rehydration, oral or IV. Red cell dehydration, through oral or IV. And then hypoxemia, kind of the point of this presentation is that oxygen therapy. So emergency management for exertional sickling, generally you're going to call 911. Administer high flow oxygen, if possible. It's our first line of defense. again, in our kind of evaluations, checking those vital signs. And I believe including pulse oximetry, is key, deciding when to administer and potentially discontinue oxygen. Attach an AED if needed. The challenging case with exertional sickling is that it can have that hyperkalemia that causes this pulseless electrical activity, and generally an AED is not going to have an advisable shock from that. It's going to have this kind of metabolic storm of that lactic acidosis, hyperkalemia, and that decreased calcium. You're able to administer fluids. Otherwise, you would tell the treating physician the athlete's having a sickle cell crisis and expect explosive rhabdomyolysis. And again, in most of the conditions that we try to deal with, it's trying to have a proactive plan and appropriate emergency equipment for all practices and competitions. Not all, athletic deaths you're going to be able to prepare for, but I think there's a lot of injuries and situations and deaths that do occur where there probably were some boxes, that weren't checked or prepared as well as they could have been. So I think it's just something, another takeaway from this presentation is really making sure in your off season, all parties involved, are ready and prepared for as much as you can. And if supplemental oxygen is something that you can get green lighted by, your treating physician and your employer, then, I think it's something that is definitely, having in your toolbox. Hopefully you never need it, but if you do, you're going to be, very thankful. And the athlete will be thankful that you have that on site. So as far as the NCAA sickle cell trait mandate, sickle cell trait testing began in 2010 in Division I. Now includes all NCAA athletes. Sports medicine staffs are using this information to educate athletes and implement tailored exercise precautions. And the numbers speak for themselves. Before the NCAA mandate, 10 out of the 21 non-traumatic college Division I football deaths were attributed to sickle cell trait. And in the 6 years that followed, only 1 out of 14. And so lives have been saved from the NCAA sickle cell trait mandate and the education and the tailored precautions that comes with it. And, with the tailored exercise precautions, again, I'd review the NATA position statement to really go over all those exercise precautions. But generally, it's, making sure an athlete isn't doing serial sprints or time mile runs. They're not, working out if they're ill. They have adequate access to hydration. And probably the biggest thing is just creating an environment where they're comfortable reporting if they're having complications or symptoms. But again, if you want all those different tailored exercise precautions, you can reach out to me or review the position statement. I think it's important to kind of, go over an update on the military sickle cell trait policies. So for decades, they kind of had a belief that preventing heat illness during training without knowledge of an individual's sickle cell trait status was sufficient to prevent ECAST injuries and deaths. Unfortunately, decades of injuries and deaths due to ECAST events and warfighter athletes has finally led to an unprecedented change in policy within the last few months. So now they are testing recruits in all branches at their initial health screening exam. It is a step in the right direction, but it's unknown if the policies will adequately address tailored exercise precautions and proper emergency management for an ECAST event. So I think this is a really big step, for the medical care for those in military with sickle cell trait. Hopefully it leads to better outcomes than the amount of injuries and deaths that the military's had for the last 30, 40, 50 years. But I think it's important to know, kind of in differentiating between kind of the theory and the NCAA and kind of some of the military policies. You can really be comfortable with, the success right now of the NCAA policy. So let's just not get content with that and continue to do the right things and, allow our athletes with sickle cell trait to compete safely. So this was an interesting study that I read. Again, only a couple subjects with sickle cell trait exercising at altitude. But I put in red kind of, the altitude level they were at, the 10, 20, 30 minutes of exercise that they were engaging in and how that corresponded with their oxygen saturation levels. And obviously, as we kind of discussed earlier, below that kind of 94% is generally going to be recommended to administer supplemental oxygen. Um, so someone with sickle cell trait, altitude, exercising, just another thing to kind of be aware of, that it does have a significant impact on their saturation levels, and maybe just reinforce how you can understand how it could become a medical emergency for that athlete. The good thing for these athletes for this study was that their oxygen saturation was back to pre-exercise levels after about 5 minutes of rest and hydration. But again, if you have access to supplemental oxygen, this could be recommended for these individuals. So right now, I want to show you an ECAS clinical case. This is going to be Clifford Melton. He's a warfighter athlete. And this presentation comes from the CHAMP Summit with Dr. Francis O'Connor. I don't think you're going to see very many videos of actual ECAS events. So I think this is a very worthwhile showing, so you guys can really see how you can get from exercise to life-threatening conditions.
While sickle cell trait is largely benign, it can be associated with significant complications to include exertional rhabdomyolysis or severe muscle breakdown, or the rare entity of exertional sudden death. What is exercise collapse associated with sickle cell trait, or ECAST? Most of these collapses, or deaths, are described in either athletes in the preseason, military recruits in basic training, or warfighters participating in physical fitness tests. The collapses or deaths are associated with marked strenuous exercise. The case reports also describe that not only is this exercise extremely strenuous, but there is frequently evidence of repeated high-intensity drills with limited periods for recovery. Additionally, not uncommonly observed is seeing someone who is struggling to catch their breath well beyond what is normally experienced. These collapses are also unique and unusual in that they are associated with marked muscle weakness, pain, or cramping. In addition, many of these collapses are observed as occurring in individuals who are initially conscious. This means that the affected individuals are not stopped by a loss of consciousness, but by marked weakness or pain. This creates a unique opportunity to intervene and potentially save a life in someone who may be in trouble. What does an ECAST, or exercise collapse associated with sickle cell trait, look like? I would like to now introduce you to Mr. Clifford Melton. Mr. Melton suffered an ECAST event several years ago during a team competition as part of a personal security detachment. He was in excellent physical condition and well trained for the event he was to participate in. The event resulted in severe muscle breakdown requiring surgery in his legs to relieve pressure and to ultimately save his life. You're going to observe him talk through what he was feeling and experiencing during this ECAST event. Importantly, before you see him running and shooting, he actually carried a 180-pound dummy body up 5 flights of stairs to simulate a rescue. While he was well trained for this carry procedure, he had limited time to catch his breath during this competition. You were at the far shooting lane.
Yes, and I got there. It was an actual open box with a mouse port. I had to shoot rollover prone. And I had 3 targets. And I had a clear sight picture, pressed the trigger on my first target, knocked it down, saw it go down. Tried to re-engage second target, everything went black. I couldn't see.
Everything went black, but were you still with it?
I was still hearing everything.
You were hearing everything?
I was hearing everything. I could hear the gunshots. I was very conscious. And so,
were you able to get up on your own?
Oh, yes. I got up.
How were your legs doing at this point in time?
They were very heavy.
Heavy legs. Okay.
Heavy legs. Still feeling the same tightness I felt.
Still 7 out of 10?
Still about a 7 out of 10.
So you're running back down to an ammo point?
At that point, and you can probably hear somebody's audible just saying something, and it says, "Come on, Cliff, move." I remember that, and I remember speaking in my gas mask, and I'm telling you, I almost felt like crying in my gas mask. I said, I'm trying, and I'm trying.
Okay. Tell us here, so you're going to be coming from the left side of the screen, and if you can describe what's happened as we're moving here.
I'm trying to keep going, just trying to push myself. I'm just like, my body is pretty much giving out. And right here, this is when my coach is still trying to motivate me to keep going.
All right, so your teammates are helping you here.
Yes, sir.
They're carrying you. And I understand this is tough to watch, but your teammates are watching, so we'll pick it up if you can describe it for us, Mr. Melton.
They told us that I had to get to that shooting box or we'll get disqualified as a team. And I just felt like I wanted some water at this point. I wanted something. If you really take a detailed look at my face, you probably can see the flushness, kind of like I felt like I was swollen. My legs were tight. I could not move them. You know how you just kind of like on a run, you're trying to drive your hips forward. I could not at this point. At that point right here, I was done.
You were done.
I was done. But I'm still coherent, knowing what's going on. I'm still thinking, hey, I still can get up here and shoot. Thinking I'm in the fight. And I'm telling you, that is where I'm dizzy. My head is, but I'm hearing everything.
What do you think are the important clues for that young warfighter with sickle cell trait to be aware of that's different?
When you start feeling that pain in your legs and when you're something that you normally don't feel, you need to pay attention to that. You need to pay attention to your breathing. You have probably been running all your life and you know what it feels like to overexert, you know how to slow your pace down. But as you get to the point where you cannot control that part of it and you're having leg pains, you may be going through a medical crisis.
Okay. Let's talk about the team and the cadre who are watching the team. What message would you have for them as they watch this?
I know they're trained or you're trained to be tough. And don't look at your teammate or the soldiers that's next to you as being, weak or being, you may want to look at the medical side of things first. You kind of need to know who walks beside you.
So some clinical case reflections, that I had for that case. Again, it was very hard to watch, but when I first saw that video, I had a lot of parallels to what I've seen over the years, either participating in football myself or, as a student athletic trainer or an athletic trainer, the way that, certain sports do conditioning programs and try to really motivate and push some athletes. So yeah, it definitely hit home for me, and I hope some of you guys could easily see what kind of standard practices, or hopefully what was considered standard practice for some conditioning events, and the motivation behind a lot of it and at it can lead to medical crises or ECAST events. So just in reflection, what actions could have been taken to prevent an ECAST event. Ideally, if Mr. Melton, once he started having some symptoms, there was that kind of environment where he could tell either a cadre of medical personnel, that he was having some issues. So then they could do, the very basic, rest, hydration, oxygen if needed, checking the saturation, and then potentially, continuing once all his, vital signs return to normal. Was the conditioning skills test reflective of a real life professional scenario? Again, this is kind of out of my knowledge and understanding. But I think, the military or a warfighter athlete, regardless of where they're at, they really need to reflect on a lot of these extreme tests and whether or not it's, really testing them for something they would actually go through, or whether or not it's, on the extreme level and not really something they would go through. So just maybe more reflection from that standpoint. And again, when should medical personnel have intervened? Again, I think a lot of us would say, once he started having severe complications and, needed assistance, but obviously once his legs were really not able to be used, that should have been when there's some intervention done as well. But again, it's always easy looking, on these situations, and not being actually in it. And in some of these high intense environments, again, that's why having these kind of standards and guidelines beforehand kind of set will make a lot of this easier in, having more positive outcomes. Luckily for Mr. Melton, he was able to at least survive, his ECAST event. So general oxygen storage guidelines and maintenance. So physician standing orders should set guidelines for administration use and when to conclude oxygen therapy. The prescription, should identify the starting dose, mode of delivery, and target oxygen saturation rate. And the guideline for ending use of oxygen and resolution of signs and symptoms is through achieving that oxygen saturation via pulse oximetry in 94 to 98% and or until, EMS personnel decision. So fire safety guidelines, local fire department needs to be alerted when oxygen is stored in a school. School should notify building insurance company that oxygen is stored on the premises. Oxygen and use signs should be posted at the entrance of all building sections, classrooms, nursing offices, or wherever oxygen is stored or potentially used. Any oxygen tank that is heard hissing or noted to be leaking needs to be replaced promptly. And there needs to be checking regularly to ensure that there's adequate supply to use in an emergency situation. Tanks noted to be less than half full or expired should be refilled or replaced. Do not smoke in the same room as the oxygen equipment. Do not use oxygen near fire or naked flame. Do not hang clothes or dusters on oxygen cylinders or concentrators. Aerosol cylinders should not be discharged near oxygen source. Do not let a concentration of oxygen build up in confined spaces and ensure good ventilation. As far as storage is concerned, don't store oxygen in the same area as flammable liquids. Whenever practical, place cylinders near an exit so that they can be removed quickly in emergencies such as a fire. Keep cylinders under cover, preferably inside and protected from extremes, heat or cold. Storage areas should be clean, dry, well ventilated, away from sunlight, highly flammable liquids, or other combustible material and sources of heat and ignition. And I'd consider, having it under lock and key as well. And I posted a couple articles down here. There recently where I'm at, there was kind of an explosion, and it was due to someone who was smoking, believed to be smoking, and there was an oxygen tank in the apartment that led to a few people being injured. And a few months ago in Baghdad, Iraq, there's a really bad explosion at a hospital that killed 82 people at least and 100 plus that were injured. So that's why it is really, really important to make sure that, you're complying with the storage guidelines and everything. And these are just kind of some general guidelines here. Obviously, if you have oxygen or are going to get oxygen, it's something you'd want to make sure all your boxes are checked from the school standpoint, from your employer standpoint, to ensure that you're kind of in compliance with what they consider to be, recommended for storage. Cylinders should be kept free of rust or dirt. Oxygen canisters should be kept at least 5 to 10 feet away from gas stoves, lighted fireplaces, or other sources of flames. Secure an oxygen cylinder to a solidly fixed object to avoid creating a missile out of the tank. Proper administration. So I kind of put up there parts of an oxygen cylinder for you to kind of briefly review. So high pressure tanks require a regulator that has a valve to turn the oxygen source on and off, a flow meter to measure and adjust the flow of oxygen, a pressure gauge to determine the amount of oxygen remaining in the tank. So you're going to open the tank by turning the valve at the top counterclockwise until the needle on the pressure gauge moves. You're going to set the flow meter to the prescribed rate. Generally, that's going to be in liters per minute by turning the dial to the number or until the ball rises to the correct level on the scale. And generally, there's going to be that difference between low flow, like 6 liters a minute, to high flow of that 12 liters a minute. But again, you should be talking with your, all parties involved in your team physician for, when you do administer, or if they want you to administer, what they would want that guideline to be. So primary options for delivery of oxygen is going to be through a face mask, ambu bag, non-rebreather, or a nasal cannula. So face mask, generally you're going to place a mask over the nose and mouth, secure with elastic strap around the head and above the ears. Mask needs to be comfortably fit, firmly against the face. Any space between the mask and face dilutes the intended concentration of oxygen. For students unable to tolerate the elastic strap around their head, the mask can be held against the face without the strap, only for a limited amount of time. Ambu bag, again, there's going to be that adjust to desired flow rate, administered by either face mask or tracheostomy connection. Again, that's probably not going to be for us, just kind of an FYI if there are some athletic trainers that are working in that setting where that would be something that they would run into. Regardless, either option requires a tight seal to the airway. Rate and force of manual resuscitation breaths determined by the medical professionals. To close the tank, you're going to disconnect the oxygen, turn the valve clockwise. To can't go any further, and the flow meter should steadily decrease to 0, indicating that no oxygen is flowing from the tank. With a non-rebreather, consists of a face mask connected to a reservoir bag that's filled with a high concentration of oxygen. The reservoir bag is connected to an oxygen tank. The mask covers both your nose and mouth, and one-way valves prevent exhaled air from re-entering the oxygen reservoir. The nasal cannula, if you're using a nasal cannula, the prongs are going to be inserted into the nose. They follow the curve of the nostrils, secure around the back of the ears, and adjust below the chin level. So I just put some pricing options just so you guys could see that as well. This would be kind of what probably be common or what we would potentially have access to. So if you go to Medco, they have these life oxygen oxygen tanks, and those are the prices for those. And then I put a standard oxygen inhalator up there. And kind of in some of my research on different modes for oxygen, there's something called boost oxygen. Some of you may or may not have heard of, and it's no prescription is required, but I do want to preface that it's not intended for medical use. But, I kind of read up on it, and it was something, I guess, that was on Shark Tank, a popular TV show. And it's done very well, I think, financially, where there are a lot of people that are actually purchasing it. Again, this is more for recreational use, but this boost oxygen, it's portable, 95% pure supplemental oxygen for all natural respiratory support. Obviously, it was a lot cheaper, more cost effective it was like $12 to $15 like for a canister. Again, no prescriptions needed. And they kind of state this is used by athletes for recovery and performance, older adults for an active lifestyle, people at high altitudes, and those experiencing poor air quality. So you can see it's pretty easy, or would be pretty easy to use. One of the testimonials that they had on their website was from a mother of a child with sickle cell trait and how it helped him during his activity and performance and exercise. He was having issues to kind of recover. So as you were kind of having discussions with all parties involved, your employers, your team physician, if they are kind of against having the oxygen for whatever reason, this is always something that you can at least mention to parents of your student athletes to consider if their child has kind of a high risk condition, if they wanted to look into having something like that to at least have access to. So just something to consider. So maintenance for these oxygen tanks, again, these are to be ready for use. Gauge indicator must be closed to the green full area to have an adequate supply on hand. The unit and mask should be kept clean with soap and water. Routinely check if the needle is in the green and if the unit's clean. Routinely turn on the unit to confirm the oxygen flow. If there's a loud audible leak at the regulator or valve connection, the regulator screw knob is not tight or it's missing the regulator valve seal. There are no adjustments to the regulator. If the user has forced the regulator, flow control knob, factory service, or replacement of the regulator is required. Just be aware that oxygen does continue to flow sometimes for a few seconds after turning off, and medical oxygen is stable and does not expire. As far as cylinder requalification, an oxygen cylinder continues to be in compliance for use until such time that is presented to the refiller to be refilled after the expiration of the compliance period allowed. An example is that Life Corporation's oxygen equipment's reign and test compliance for use until presented for refill anytime more than 5 years after the manufacturer date stamp or subsequent date stamp. The refiller must requalify, test the cylinder, and stamp the current date. So before I get to kind of proper administration, I'm going to go back. So for those Life oxygen packs, the one in the middle there, it's a little bit different than kind of the oxygen canister. So it's even more simple. So generally there's going to be kind of an on-off valve for, the low flow to the high flow back to the off. But what I'm going to show you now is going to be kind of proper administration for an oxygen tank. Hopefully some of you find this, somewhat comical. This is just a picture of a football athlete that for whatever reason, put the face mask on his ear when it obviously should go over his face. So sometimes common sense isn't always common. So it's a good reminder that, we have to, there's reasons that we go over proper administration of certain things, even though it may seem simple. But here's a video of administration of oxygen therapy, especially with me not being there in person. I thought this athletic trainer or professor at Bethel University does an adequate job, and hopefully gives you guys a good idea of how you would use like an oxygen cylinder.
This particular task is administering supplemental oxygen. And this can be used in a variety of different settings, depending on the issue that might arise. You could use this for an individual that might be in respiratory distress. So they're having difficulty breathing, but they are still breathing. Or you could use this in a situation where they are in respiratory arrest, meaning they're not breathing at all, and so you're increasing the percentage of oxygen that you're delivering via your bag valve mask. Because of the severity of the situation, all these tasks need to be done fairly quickly, and there's quite a few of them, so you just always need to keep that in mind, and you always want to make sure that you're practicing and are fully aware how to do this very quickly, because there's a number of different parts and pieces to the particular equipment. So the first thing is that we need an oxygen tank. One thing that's helpful is to make sure that the oxygen tank has oxygen in it, and so you want to check and test that on a regular basis, minimally annually, to make sure that you have enough oxygen to be delivered when you need it. This is a type D tank, which means that you have approximately enough oxygen to be delivered for about 40 minutes with the use of the regulator. If not, it will all blow out in a couple of seconds. A couple of safety procedures when you're utilizing the oxygen tank. One is that you don't want to use the oxygen tank around a fire, because the high percentage of oxygen will increase that and create problems with the fire. You always want to make sure that it's nice and secure, because if for some reason, if this falls or if this breaks off the nozzle, because it's compressed air, this can go shooting out and hit somebody and cause substantial damage. So you always want to make sure that you don't just have this standing somewhere so that way it could fall. You always want to make sure that it's nice and secure. First thing though, I am going to stand it up just to kind of demonstrate a couple things regarding the tank. One of the things is that first thing that you want to always do is just turn the tank on just a little bit to blow out any dirt or any particles that might have kind of got onto the entrance. So just blow it out just a little bit to flush any air out of that particular area. So then what I'm going to do is I'm going to take what's called my regulator. And what this does is that this limits the amount of air that's actually coming out of the tank and going into the tube and into that person, whoever that might be. So it really limits it to a very slow rate. So you always want to use a regulator, otherwise you'll go through your tank quickly. You want to make sure that you fit the regulator onto the appropriate O-ring, which is always going to be kind of right on one of these sides here. So you want to check that to make sure that you're dealing with it in the right particular spot. Our regulator is going to place and go securely onto the oxygen tank, and then we're going to tighten this onto the oxygen tank. This doesn't have to be super tight, because the compressed air will help pull and secure that into place. So you'll notice here we've got our tank measurement. So when we open it up, it will show us if the actual tank is full or not full. So as we open that up, you'll start to see that we're not fully full, so we wouldn't have a full 40 minutes, but we definitely have enough to be able to at least use oxygen until the EMS comes. So for demonstration purposes, I'm not going to have the oxygen run the entire time that we're talking, but we're going to assume that it is kind of functioning normally. Once the oxygen tank or the regulator is on and oxygen is flowing through, then we determine what type of breathing device we're actually going to use. If I had an unconscious individual where I was going to use my bag valve mask, one of the things that you can see here is that I can easily just attach the oxygen hose directly to the bag valve mask. It's actually going to fill up this bag below with 100% oxygen. As I kind of breathe in, it's going to draw that oxygen into the bag and then directly into the victim. That way we're getting a high percentage of oxygen into the particular victim. So here we would just use our standard technique of using our bag valve mask either with or without a inserted airway, and we're able to kind of breathe a high percentage of oxygen directly into that particular individual. If they were only just dealing with respiratory distress and not respiratory arrest, we might use a variety of different breathing devices. This particular one is what's called a non-rebreather. The hose is going to insert directly into the mask just like this. This goes directly over the face of the individual. We can kind of pinch the nose down to make sure that this is nice and secure, okay? And then as they slowly breathe, they're actually going to breathe in a much higher level or percentage of oxygen. In addition to this, we could hook this onto a nasal cannula, which is just going to wrap around the ears and just go right underneath the nostrils and plug in, and then they can actually breathe that particular way. So we'd use this to make sure that they're getting a high enough level of oxygen in. We might monitor them with a pulse oximeter because we want to make sure that we're not getting them too much oxygen or too little oxygen. And as we continue to just monitor them, they would continue to breathe. If we ran out of oxygen, then we would need to either get another tank, or hopefully by then EMS would come with a much larger tank that would be able to transport them to the emergency room.
All right, well, I hope that video helped show some of you guys, if you haven't seen or used oxygen before. Obviously, with me not being there in person, I thought that was a good way to really show you guys kind of an actual video demonstration. If kind of, verbal statements, obviously it doesn't do enough for probably some of you, but hopefully that helped you guys kind of see, that in process and use. So in conclusion, hypoxemia is the key determining factor for when we should administer supplemental oxygen therapy in the pre-hospital care of an athlete. I personally believe supplemental oxygen is a luxury that every school can afford. The cost is what I would consider minuscule when compared to the consequences of not having access to it during a medical emergency. But I also understand that, all of us are going to be put in different situations with either our employers or the schools or whoever that are going to set the guidelines, or our team physician. So I understand sometimes our hands are tied, but if it is, hopefully this, presentation is at least kind of a starting point for you, if you haven't had it already, to have with all parties involved, including your team physician, whether or not, supplemental oxygen, is something that you can have on site, especially if you're at a school that doesn't have a very quick response time from EMS. I definitely think, it's worth having those discussions and hopefully convincing, the powers that be, that it's worth having. Again, hopefully it's never used, but if you do need it, then it could be something that, could be the difference between life and death, especially after we went over the tragic case of Rashidi Wheeler at Northwestern. But I also want to talk about Rashidi Wheeler's lasting legacy. One of the things is his mom didn't want him to be forgotten. And my hope is that I'm sure most of the athletic trainers at this conference are in Illinois, or, regardless of the state you're at, if there's kind of an AED law, every time you look around and see an AED, hopefully you can think of, Rashidi Wheeler and, as far as remembering his legacy that kind of led to potentially AEDs being on, some of our sidelines or at some of the facilities. But another thing that I want us to think about didn't come from his death. Again, is whether or not supplemental oxygen, would have helped prevent it, his asthma attack, going to that cardiac arrest. So try to remember Shady Wheeler, his lasting legacy, and I really want us to think about evolving that next man up mentality. Let us teammates, coaches, medical personnel worry and be empathetic about the individual that's down. Here's my contact information if anybody has any questions. Again, I hope this presentation did an adequate job of at least kind of, covering a lot of different areas, but at least giving you, kind of that foundational knowledge so you can go to your supervisor or your employer if it's something you're interested in, and having those conversations of, whether or not supplemental oxygen is, something that you can have on the sidelines. And, with it being 2021 and the further we get out, I would think that it is going to be something that is going to be more standard and recommended, and not just considered kind of a luxury that only, Division I schools can afford. So again, reach out to me if you have any questions. And thanks to the Southwestern Conference for asking me to kind of present on this topic. And I hope that did a good job for you guys. Enjoy the rest of your day.